1.5 millimeters. And then you have about another 2 millimeters there until you reach the periosteum or the perichondrium. So the bevel of the needle I'm using is 1.2 millimeters. So if I go in perpendicular, that means that my needle will touch the end point, which will be either the periosteum or the perichondrium, but as soon as I press on the plunger and I start extruding this viscous, like high G prime filler, it probably will redistribute to one of those layers that I don't want the product to be in. So the way around this is I go in at around 45-degree angle and with the bevel down, and I do micro aliquots of deposits there. So we would do a deposit. If we can go back to the other view, please. So if we want to camouflage this little nasal bump here, we're going to draw this nasal bump here. So this is essentially where we don't want to place any filler. And then we're going to place our product just above it in the midline in order to fill this area just above where that dorsal bump is. And then we're going to do exactly the same here on the perichondrium, just below it. And these are tiniest micro aliquots of fillers. So we're going to be using probably around 0.05 and 0.05 on each one of these. Now, what else could we do, which our beautiful model is not indicated, but we could potentially do, is we could target these lower lateral cartilages here in these little domes that we have there. And we can target the highest portion here and do these two little injections in order to create, if we can just go to the profile, please, in order to create a little bit more of a super tip here in the nose. Then another treatment that we could potentially do if we wanted to influence this nasolabial angle, so we have, for example, the male nasolabial angle is around 90 degrees, and if we wanted to make it like our patients, which is around 105 degrees, you can target the maxillary spine, so you can do this with a needle straight down to periosteum, or even with a cannula. The way I like to do it is I go in with the cannula from the tip through the columella, and from the nasal spine I will do a little retrograde, and that will help me elevate these nasolabial angle. Now, if we think about the aging process and how it influences the nose, remember the piriform aperture becomes wider and the tip of the nose will slightly rotate down. So if you wanted to treat that aging process and treat this nasolabial angle, you could also treat the deep piriform space on both sides and the nasal spine with the columella in order to bring that nasal tip up. So in my experience, when you do this for treating the aging process, it's one of the nicest treatments that you can do, carry out for your patients. Now, we don't look at the nose, as you can see, we're looking at our beautiful patient's profile nose, so we don't look at the nose in isolation. Remember, like any other treatment in facial aesthetics, it has to be in balance and harmony with the rest of the face. So what else are we looking at in our patient's profile? Well, one of the things that we've been looking for, if we look at the forehead, so you want to see a nice 12-degree convexity, as you can see here. Then you look at the nasal frontal angle, we're going to slightly influence this nasal frontal angle with our HA filler, and then the nasolabial angle. Now, the next thing we'll look at is the anterior projection of the cheek. So our patient a few months ago had some dermal filler to her cheek, so you can see that she has a beautiful anterior projection of the cheek, which is what we want to see in a female patient. So if you draw a line from the lateral canthus medially, we want to see a 2:1 volume ratio. So we want to see more anterior projection, and that's exactly what we see. Sometimes in young patients, you might find that there's a degree of maxillary hypoplasia. So we do deep injections, for example, in the deep medial cheek fat, in the medial soothe or lateral soothe, in order to augment that maxilla, so to create that anterior projection. Then if we go to the lower third, so I like to use this burstal line, which goes from the subnasale to the pagonium. So roughly, let me see if I can just point, there we go. So this line, basically, why do I use this line? So this line will help me assess how much the lips should be projected in relation with the chin. And why don't I use the E. Ricketts line? Well, because if your patient has a long nose, then you're going to be over projecting the lips. So that's why for me, I will use the Burstone line here from the subnasale to the pogonium, and you expect to see that the upper lip will be around 3.5 millimeters from that line, and the lower lip around 2.5 millimeters from that line. So we have those proportions here, even though our patient has had some lip fillers in the past, but you can see how she has perfect proportions there. But then we come to the chin. So the chin is another treatment that our beautiful model has had in the past. And you can see that it is exactly where we want it to be. So it is just touching that Burstone line. But what we will do here is by increasing this nasofrontal angle, immediately it can potentially make the chin look slightly retrognathid. So what I will do in order to compensate for this is I'm going to do one point in the chin. So if we can just go to the top camera, please. And there are 3 orthognathic points that you can use to treat the chin. So there's the pogonium, the point of masculine anterior projection. Then there's gnathian here, which will help you elongate and also create anterior projection. And below here, there is menton. And what I will do is just treat the gnathian here with a very, very small debole, is the same product that we're using for the nose, in order to just slightly elongate the chin and to complement that anterior projection that we're giving in the nose. So Dario, while I get ready, do we have any questions so far about the assessment and the technique that we'll be using? So we're going to use a high G prime product, which is 25 mils of HA. It's 10% cross-linked, so it's a viscous, very cohesive gel that we will be using here. And we're going to use very, very low volumes, I estimate. So I think I'm probably going to use around 0.1 in total for the nose, and then maybe 0.3 for the chin. I guess we all agree here that our beautiful patient doesn't really need that much, and most patients this age don't really need much, but it's important that we discuss some of the things that we can achieve with HA fillers, even if we're not carrying out those treatments. Now, one of the other limitations, if we go back to the profile, please, is if your patient has a very high nasofrontal angle, even if they have a dorsal bump in the nose, we might not be able to treat it because you are going to increase the nasofrontal angle up to a degree where they probably will see the nose start from the glabella. So it's important that we don't go above the nasion here, where the frontal bone meets the nasal bone, usually around the height of the eyelashes if your patient has their eyes fully open. So what I usually do is I will have a look at the profile of my patient, and if with my pen, if I can fill that area below my pen there without going above that blue line, then I can successfully do a non-surgical rhinoplasty and deliver a natural outcome. But if my pen was like this, then the aesthetic outcome would be poor in my opinion. So we're going to start with the bony septum here. So we're going to start from the top, and then I'll work my way down. If I wanted to influence the nasolabial angle, I will start from the base of the nose, and then I would work my way up. Because I often feel that by rotating the nasal tip, you can sometimes camouflage a little nasal bump, and you might not need to do an injection here on the perichondrium. So that's the sequence. So right now, because we're just working on the dorsum of the nose, we're going to do the bony septum and then the cartilaginous septum. But if I had to do some work here for the nasal tip, for the nasolabial angle, I will start with the nasolabial angle first. Okay, so we're going to start with our injections. Are you ready? Okay, perfect. So if you just turn towards me a little bit. And I think we're going to go for the top camera, if that's okay, guys. Let's see if we can get a good view there. Excellent. So what I like to do here is I do this targeted digital pressure. So if we can just zoom in as much as possible, that would be great. And this, I'm compressing this dorsal nasal artery here. And then we're going to go in bevel down. So this is ultra deep that we're going to be using. So I touch the periosteum, and we're going to do tiny, tiny bolus here. So this is a slow injection. Remember, a slow injection is the safe injection. And I'm going to use around 0.05 here. I don't decant the product. I use the product exactly as it comes from the syringe. I did change the needle ever so slightly because I'm just going to have it. If we can put another needle on it. And the needle that usually comes with this product is a 25 gauge 2-inch needle. That, in my opinion, is too big for the nose. So now if we can just have a look at the profile again and see what we've achieved so far. So we can see that that was, in terms of the volume that we used, that was exactly 0.05 actually. And we already start to see that there's a straighter bony septum there. And you can see that increase in the height of the nasal frontal angle. Now, I'm going to do one final injection here in the nose, right here in the cartilaginous septum, so just below where this dorsal nasal bump is. And I've changed my needle, and we'll do exactly the same thing, and we'll do our targeted digital pressure. We're going to do bevel down, another injection here. So targeted digital pressure here. If we go to the top camera, please. And a little scratch here coming up. So kiss the perichondrium, and again, small bolus. I'm thinking this one's going to be less than my previous one. So I've done my whole treatment here with less than 0.1. So these are 1.2 cc syringes, and we've only used a little bit.
Rob, can I make a question?
Yes, please.
Which kind of filler are you using? Is it the low, intermediate, high G prime filler? And does it matter to use whatever the filler, or are you selecting?
This is a great question. So this is called Ultra Deep from Teoxin. So it's a high G prime, very cohesive product. So if we can go to the profile view, please. It is 25 mils of HA, so it's high concentration HA and high cross-linking, 10% cross-link. So it's a super periosteal volumizer, which is very cohesive. So you want a product that is not going to spread, a product that won't that will stay in place, a product that is rigid. So if you want in rheological parameters, for me, what would be more important is high cohesivity here for a treatment like this. So you can see this is a very, very subtle treatment with 2 injections. But now what we can hopefully appreciate is that we have a straight dorsum here, and you can always get just a small amount of inflammation after you do your injection. So that is expected, and you can palpate and feel exactly where your product is. You could mold it for the next couple of minutes there when you're doing it. But one of the things that we can see now is you have a straight nasal dorsum, so you have a slight increase in the nasal frontal angle, straight dorsum, then you have a super tip and a small depression here, and that has complemented also that beautiful nasolabial angle here for our patients. So this was all done with a small amount of product, but one of the things I will usually say to my patients is when you treat the nose, so remember, we don't like to treat areas in isolation. So what we want to do is treat the whole profile, because that's what we can influence the most with injectables, which is the profile of the nose. From an anterior view, If you increase this nasal frontal angle, you might make a wide nose look slightly narrower and improve the light reflex and even camouflage a slight septal deviation. But most of the improvement that you will be able to accomplish with a treatment, non-surgical rhinoplasty, is in the profile. So remember, we look at the whole profile. We're going to look at the projection of the anterior midface and the chin and the relationship with the lips and the chin and the nose. So you're going to probably have some product left. So I mean, in my practice, I charge for the treatment, not for the product. But remember, it's a great opportunity for you to enhance your patient's appearance by treating the chin or the midface, whatever the indication is. So the last injection I'll do is in the nathium here. So we're going to try and do this to slightly elongate the chin. So this is a deep injection. And we're going to do with the same product, which is ultra deep, 25 milligrams per mil of HA, 10% cross-link, very cohesive gel. And you can see how I lost the whole depth of my needle there to touch the periosteum. And the reason for that, remember, it's because we have a patient that has had dermal filler treatments there in that chin in the past. So I just wanted to slightly elongate the chin and to complement what we've done here for the nasal frontal angle. So if we can look at the anterior view, the top view please, thank you. Thanks guys. So you can see how the light reflex has slightly improved here in the nose. So it looks almost completely straight there. And we can see how the shape of the chin has very slightly improved with just a 0.2 cc of filler, the same filler there into the nathium there of the chin.
Thank you, Raul. It's extraordinary results. Can we ask for a few questions since you have been very exhaustive with the explanation?
Of course.
I do have a question, and see the audience have a question for you. Will you recommend this procedure to beginners, like non-surgical rhinoplasty? Will you recommend it for beginner? And I saw you, or maybe I missed, that you didn't do aspiration. Do you have any tips for that? Do you think it's not necessary to do aspiration? And first question is mostly, do you think it's a procedure that a beginner should do or not? And some comments.
Thank you. So this is definitely, it's a high-risk procedure, so it's an advanced procedure. So if we can go to the other camera and get me on camera. Can you zoom out so I'm in the shot? Thanks. This is definitely an advanced procedure, Dario. So we can see from your presentation and what you presented in terms of the anatomy there, it's quite a high-risk procedure. So if you look at the incidence of probably the most catastrophic complication that we can get from HA fillers, which is blindness, the nose is the #1 area for this catastrophic complication. So this is definitely something that you want to progress in the later part of your career, once you're more proficient with other things and you have a network of colleagues around you to help you with any complications. So that's what I would suggest. And you know, Prof. Saeed did another beautiful presentation there, and Carlos, I'm sure, is going to do another one there with the complications. So you're going to see what you can potentially encounter with these treatments. So they're high-risk treatments. So definitely one of the later treatments that you want to evolve in your injection career. Now, for the other one that you asked in terms of aspiration, I think there are several things that we can use in order to deliver a safe and effective injection. And if you look at the evidence base behind it, aspiration will probably have the lowest evidence base in terms of its reliability and specificity. So when I do my injections, I'm doing things like adjusting my angle of injections, I'm moving the tip of my needle, I'm doing slow injections, because remember, slow injection is under low pressure. I don't change to a smaller syringe in order to increase the pressure of the product being injected. I do it very slowly. Why? So that I can keep an eye on my patient, keep an eye on the anatomy and all of and the skin and the tissues as I'm injecting. And remember, if you're going to aspirate, there is enough information there for you to know how long for and how much you need to aspirate for, and other factors like, are you going to prime the hub of the needle and the needle itself with saline, and you have to aspirate for these high deep prime, very cohesive fillers. I would have to be aspirating around 0.4 for around 30 seconds almost. So that's a very, very long time for me to remain perfectly still. We also have other evidence, with ultrasound, with, expert aspiration, two-handed, one-handed, and the needle tip is probably going to move around 3.5 millimeters per second there while you're doing this. So all of these factors you need to factor in. So I'm not saying don't aspirate, I'm just justifying why I don't do it based on the evidence base, but there are a lot of things that you could be using in order to ensure the highest possible safety for your patient, and just familiarize yourself with the evidence that is out there. So if you aspirate, you can aspirate correctly.
Yeah, so there are two quick questions and then we have to move to the next lecture.
Raoul, may I ask a question? Great presentation, lovely demonstration of technique. Two of the things, you made it look very straightforward, it is not, and your assessment was so comprehensive, and that's very key. It's not a beginner's type of procedure. Can you tell me when and if in certain cases when you may be using a cannula as opposed to a direct needle injection, and what do you tend to suggest under those circumstances? Are there any specifics that you look for when you're doing that?
Absolutely. So I use a cannula for the nasolabial angle. So if I'm going to treat the maxillary spine and the columella, I do that with a cannula going from the tip of the nose through the columella and the nasal spine, and I do a retrograde. In my hands, that works very well. And instead of doing 2 injections there, so that's when I use the cannula. I find that for the dorsum of the nose, I've used cannula there, and you have to just familiarize yourself with the pros and cons. Similar to with the under eye. If you're using a needle or a cannula, cannulas tend to cause slightly more edema, and then needles. Needles are more likely to give a bruise, for example, in certain areas. But here in the nose, if you're going to use a cannula, what I would suggest is to do, if you're trying to camouflage a dorsal nasal bump, is to do 2 entry points, one below it and one above it. Because if you try and pass your cannula through a nasal bump, you're going to redirect the angle of your cannula. So that means that your cannula will be more superficial, and you're going to be injecting where you don't want to place filler. So I do use cannula in the nose, and it just depends on what I'm trying to achieve during my treatment.
Thank you.
Great, so no more questions, so I think we